Welcome dear friends, once again in the second teleconference session. This is the last sessions of today, and in the previous sessions we have learned so many things from Dr. Anuradha regarding the common emergencies of the elderly patients, and she also described how to take care of all these elderly patients and how to identify all these patients. In these sessions we are basically going to learn about the accidents and poisoning of the elderly patients, as well as balance disorder of those elderly people. And for this we are having experts from Maulana Azad Medical College, Dr. Kaur, and as all of you aware that our elderly patients has got a different behavior pattern, different their environment, and their movement also very different from the young adults. So their nature of the accidents and nature of getting poisoned and their balance disorder is entirely different, and this is the things we have to differentiate from the young adults to elderly patients. And I hope that all of you will be benefited by the Dr. Kaur, and he will be describing all these things to make you understand more regarding this topic. So I would like to request Dr. Kaur to start this topic, please.
When we talk about the poisoning in the elderly, we find that the risk of suicide by all means increases steadily with the age. Elderly have reduced renal and hepatic functions, which may lead to increased risk of toxicity with therapeutic dosage of the drugs. And further, many a times the use of multiple drugs for multiple problems in them leads to the drug interactions. Further, many elderlies are predisposed because of the fact that many doctors sometimes prescribe similar medicines, multiple medicines, while treating their illness. Self-medication is also a very important problem in the elderly, and many times they would fail to understand the dose, and the drug toxicity may be sometimes confused with the signs of aging by the physician, and it is also a fact that the changes in the drug receptors may produce exaggerated response to some drugs. Now, while you are dealing with a case of drug toxicity or poisoning in an elderly, it is important to elicit a very good history from the closest relations. If the patient is able to give a good history, it is fine, otherwise from his relatives. And certain things needs to be known. What was the poison involved? How much poison was taken? When was it taken? By what route it was taken? What else was taken along with the poison? What are the drugs or chemicals available at home? What is the occupation of the patient? Because sometimes the professional exposure to certain chemicals may predispose them to develop toxicity. After the good history is obtained, it is important to have a very good physical examination from head to the toe, and also to diagnose the type of the poison and to detect any associated trauma. Now, based on the examination, it may be possible to identify the type of the poison which has been involved. So while making a physical examination, you need to be very careful to pay attention to certain features like the odor of the breath, any evidence of hypertension with tachycardia, any evidence of hypotension with bradycardia, any evidence of hypotension with tachycardia, any evidence of hyperthermia. Because these features may indicate the type of the toxin or type of the poison which has been consumed. For example, if you have consumed chloroform, ethanol, cyanide, arsenic, organophosphates, kerosene, it emits a particular type of odor. If you have consumed any of these poisons like amphetamines, cocaine, marijuana, alcohol withdrawal, or nicotine, or antihistaminics, or antipsychotic agents, or antidepressants, you may be able to find that there is hypertension with tachycardia. On the other hand, the excessive consumption of antidepressants, the barbiturates, narcotics, the benzodiazepines, the cyanides, nicotines, and organophosphates are associated with hypotension with bradycardia. Aluminum phosphide, antipsychotics, caffeine, cyanides, tricyclic antidepressants when consumed in excess leads to hypotension with tachycardia as a dominant physical finding. Similarly, you may find hyperthermia associated with amphetamines, antidepressants, MAO inhibitors, anticholinergic agents, the salicylates, and antihistaminics. Hypothermia is a feature which may be seen with consumption of ethanol, benzodiazepines, narcotics, barbiturates, and phenothiazines. Similarly, the patient may be tachypneic, and tachypnea is a feature of amphetamine, atropine, cocaine, salicylates toxicity. Bradypnea is a feature of associated with excessive consumption of antidepressants, antipsychotics, barbiturates, ethanol, benzodiazepines, narcotics, organophosphates, and altered sensorium may be seen with the excess consumption of the antidepressants, antihistaminics, antipsychotics, atropine, organophosphates, poisons, barbiturates, lithium toxicity, cyanide, benzodiazepines, ethanol, narcotics, and carbon monoxide. Seizure. Repeated seizures could be a feature of associated with consumption of antipsychotics, antihistaminics, organophosphates, leads, heavy metals, lithium, narcotics, amphetamines. The pupils may be constricted or miosis, which is a feature of barbiturates, phenothiazine consumption, ethanol, narcotics, nicotine, and organophosphates. Mydriasis is a feature associated with toxicity of amphetamines, caffeine, cocaine, MAO inhibitors, nicotine, antidepressants, antihistaminics, and atropine. Cyanosis may be a manifestation associated with methemoglobinemia, and it may be seen in many cases of terminal stages of poisoning. Once you have made a history and physical examination, certain simple bedside tests need to be done for the purpose of confirmation of the type of the toxins consumed, and also for the purpose of fulfilling the legal formalities. Now, a pinkish color of the urine, if you examine the urine, you find it's a pinkish in color. This is likely to be seen in phenothiazine intoxication as well as in myoglobinuria and hemoglobinuria. Chocolate colored urine is indicative of methemoglobinemia. If you examine the urine macroscopically and you see plenty of oxalate crystals, this is typical of ethylene glycol ingestion. Ketonuria without any metabolic change is seen in isopropyl alcohol and acetone intoxication. Ketonuria with metabolic acidosis is suggestive of salicylate poisoning. So urine examination is very important, which needs to be done, which needs to be preserved for detecting certain toxins which the elderly patient may have consumed. Radiological investigations are equally important. An X-ray of the abdomen may be sometimes carried out because certain radio-opaque toxins can be detected, which include chloral hydrate, heavy metals, iron, iodides, phenothiazines, sustained release preparations of iodides and phenothiazines, and certain solvents like chloroform, carbon tetrachloride. However, if the X-ray is normal or no radio-opaque substance is detected, it doesn't exclude the basis of poisoning. Certain basic principles have to be followed while managing a case of poisoning. These general principles are: number one, all patients needs to be resuscitated in the initial phase of admission. The diagnosis of the type of poisoning is based on history, examination and simple laboratory investigations, which I have already spoken. There may be some non-specific therapies may be carried out to reduce the level of toxins in the body. Of course, specific therapies need to be also carried out to reduce the toxin effects on the body. Besides the specific therapy, we need to associate supportive care to support the functions of the vital organs. Now, how do you manage a case of poisoning in the elderly? First and foremost thing is that we need to do a nasogastric lavage with the patient in the left lateral position and the head in lowered. However, nasogastric lavage should never be performed if you are suspecting that the person has consumed caustics, or if you are suspecting that the person has consumed some non-toxic agents and volatile hydrocarbons. The gastric lavage should not be also considered unless the patient has ingested a potentially life-threatening amount of poison and the lavage can be taken out within 60 minutes of the ingestion. Beyond 2 hours of ingestion, the decision to perform the lavage is based on individual cases. The other way of getting rid of the toxin from the body is to take help of the cathartics, which help in the excretion of toxins from the gut. But the use of cathartics has got certain disadvantages. Disadvantages are that it may predispose to electrolytic imbalance, dehydration, and it may cause distension of the abdomen, and this cathartics cannot be used in presence of paralytic ileus, intestinal obstructions, renal failure, hypotension, severe diarrhea and abdominal trauma. The common cathartics which are used are the magnesium sulfate, the magnesium citrate and sorbitol. Now, despite the theoretical benefits of the cathartics, there is no data available at the moment to support their efficacy, and their use cannot be recommended at present. The third principle of getting the toxin out of the body is to induce forced alkaline diuresis, which can be achieved with the help of furosemide therapy, which is needed to maintain the high urinary flow, but at the same time you need to support the circulation by administering 5% dextrose in half normal saline containing 20 to 35 milliequivalents of bicarbonate at a rate so as to produce a urinary output of 3 to 6 ml per kg per hour and a urinary pH of 7.5 to 8.5. Every second or third bottle should be supplemented with potassium chloride to avoid hypokalemia. It is important to monitor the patient closely during forced alkaline diuresis, and the monitoring parameters includes the vitals of the patient, the inputs, outputs, the electrolytes and the acid-base status. This procedure should not be used in patients with shock, hypotension, renal failure and congestive heart failure. The other way to get the toxin from the body out is to use activated charcoal. Multiple doses of activated charcoal have been found to be useful in certain poisoning. The dose varies from 0.5 to 1 gram per kg body weight every 1 to 4 hours. Now, the multiple doses of charcoal are indicated as a therapy in following conditions: where you believe the toxins which has been consumed has a long life, toxins which have been consumed has a significant enterohepatic circulation like digoxin, phenobarbital and theophylline. Dialysis, hemodialysis is also an important modality to get rid of the toxin from the body, and dialysis is considered to be useful in ethanol toxicity, methanol toxicity, salicylates, theophylline, ethylene glycol, phenobarbital and lithium intoxication. As compared to hemodialysis, peritoneal dialysis is considered to be a slow process and is only 10 to 25% as effective as hemodialysis. After getting the toxins eliminated from the body by virtue of the different methods which I mentioned, you also have to give a specific antidote if it is available. For example, if somebody has consumed the organophosphorus poisoning, and we have to specific antidote is atropine, which is to be given 2 to 4 milligram initially, repeated every 5 to 15 minutes unless there is cessation of the oral and bronchial secretions, tracheal secretions. Then lower the dose and give at least frequent intervals to maintain optimization for 48 to 72 hours. Palidoxin can be also given for organophosphorus poisonings, 1 to 2 grams IV over 10 to 20 minutes and repeated every 4 to 8 hours. For the opiate poisoning, we administer naloxone, and for the methemoglobinemia, the antidote is methylene blue, 1 to 2 milligram per kg as a 1% solution, to be given slowly over 5 minutes intravenously and may be repeated after 1 hour. If it's an ethanol, if it is a methanol poisoning or ethylene glycol, then you have to give ethanol. Loading dose is 0.75 grams per kg body weight, which is followed by maintenance dose of 0.1 gram per kg per hour. For the iron toxicity, you have the desferoxamine as the specific antidote. The dose is 90 milligram per kg body weight up to 1 gram intramuscularly, followed by same dose every 4 to 12 hours. If hypotension is present, it should be given IV at a rate of not more than 15 milligram per kg per hour. For the snake bites, you have the anti-snake venom, and the dose varies with the species of the snake bitten and the severity of envenomation. Lead, arsenic and mercury toxicity, we have the BAL, that is the dimercaprol, which is given 3 to 5 milligram per kg body weight every 4 hours for 2 days, and then 2.5 to 3 milligram per kg body weight every 6 hours for 2 more days, and then every 12 hourly for 7 more days. Besides the use of antidote, you have to also have the supportive therapy for the maintaining the vital functions of the other organs of the body, and so that the toxin is eliminated from the body and the patient resumes normal physiological functions. If the patient is comatose, if the patient has seizures, if the patient has hypertension, arrhythmias, hypoxia and acute renal failure, you need to undertake specific measures to meet with these problems, and also monitor the fluid, electrolytes and the acid-base status very closely. The management of the poisoning in the elderly is not over unless you have also completed your legal responsibilities. That is, as I have mentioned earlier, that you collect the first sample of the gastric lavage you performed and other relevant body fluids like urine and blood in clean bottles, seal the bottles using a glue paper, affix the signature on the label, and then informs the police after the initial management. Therefore, the success of the medical management of a poisoning case is a team approach involving your several junior house staff as well as the other persons in the medical unit to achieve complete success. Besides the poisoning, we also find that these elderlies
May I have some questions?
Yes.
Like most of our doctors, they're working in primary care setup or secondary care setup, where all this antidote may not be available at the moment when it is necessary. They need to refer the patient to some tertiary care hospital and all these things.
Yes.
In some cases, history may be available. In some cases, history may not be available. So what they are supposed to do at the moment in this special primary care setup, and where they need to again transfer the patient to the
I think what is important is that in the initial phase, if you don't find the if the history is not available, then you need to immediately support the patient they support the circulation of the patient, see whether the patient, the hypertension is there, or if the patient has any features of aspiration, keep the airway clean, support the circulation, start fluids, okay, and then you can refer the patient to the nearest place where the other principles can be adopted for the elimination of the toxin from the body. As I have already mentioned, there are several ways.
Yes, sir.
We can use, you can try to see if the nasogastric lavage can be done, or you can try to eliminate the toxin with the help of activated charcoal therapy, or you can try forced alkaline diuresis. So these are the various, or sometimes even you can use hemodialysis to get,
because most of the elderly patient, I think this history may not be very much precise.
Yeah, history sometimes may not be very clear, and unless the patient's close relations have been monitoring his activities from time to time and are familiar with whatever drugs he is consuming.
Especially drug toxicity and all these things are very important, because they are always consuming the drugs like elderly patient, and they may consume like larger dose.
Yeah, he may consume larger dose and he may not be this thing.
Thank you, sir.
We also have that we find that they are very prone to accidents, and this is because it could be because related to some disorder of balance. The process of aging makes the individual vulnerable to surrounding by virtue of the following body changes: reduced daylight visual activity, reduced night vision. They may have reduced hearing. They may have associated comorbid conditions, medical conditions. Alteration in judgment due to synaptic change in the brain. They may be slow because of the arthritis or because of the associated medical diseases like chronic lung and heart disease, and reduced muscle mass while crossing the roads, and therefore they may be prone to accident. They have a longer reaction time. Further, these cases in the elderly who have frequent history of frequent falls may be predisposed because of the environmental hazard, predisposed because of the fall from the bed, gait disturbances, balance disorders or weakness. They may have pain related to arthritis in the joints, or they may be having vertigo, or they may be on multiple medications, or in some individual if they have a history of any chronic alcoholism. Acute illnesses, if they are having, that also can predispose them to fall. Those people with the aging, they can have confusion and cognitive impairment that could lead to frequent falls, postural hypotension, visual disorders, central nervous system disorders. They may have some syncopal attacks, drop attacks, epilepsy. In all these situations, if it exists, they are predisposed to the balance disorders. Further, they may be on certain drugs which may increase the risk of falling. For example, if they are having sedative, hypnotic and anxiolytic drugs like the long-acting benzodiazepines, or if they are having for a long time tricyclic antidepressants, phenothiazines and butyrophenones, antihypertensive drugs or other cardiac medications which predisposes to postural hypertension, corticosteroids, non-steroidal anti-inflammatory drugs, anticholinergic drugs, hypoglycemic agents, any medication that is likely to affect the balance of an individual. Now, while evaluating a patient, if you remember the word "I hate falling," probably the physical findings which needs to be emphasized in such a case can be easily remembered. I stands for look for inflammation in the joints. H, look for any evidence of orthostatic hypotension. a difference of systolic blood pressure more than 20 mm in the lying and the standing indicates that the patient is having evidence of postural hypotension. A stands for auditory and visual disturbances. T stands for any tremors indicating Parkinson's disease. E stands for any equilibrium problem. F stands for examine the foot for any foot problems. A stands for look for any arrhythmias in the heart, heart block or valvular disease. L stands for the leg length discrepancy. Further, lack of conditioning. L stands for lack of conditioning, generalized weakness in the limbs. I stands for any illness. N stands for general nutrition of the patient. And G stands for gait disturbance. So I hate falling is the general policy principle. If you try to remember this, then while evaluating a patient of a person who has frequent falls, probably you need to be very careful while examining this patient with respect to this particular features which I have pointed out. There are certain interventions which are needed to be done to reduce the risk of falling in the elderly. For example, if you find a person who has evidence of postural hypertension which predisposes them to frequent falls, you can advise the patient to use pressure stockings. Or in cases, if you think that the drug is the cause, antihypertensive or drug is the cause which is causing this postural hypertension, reduce the dose. Or if necessary, discontinue the drug. But in difficult cases, if postural hypertension, they can be put on fludrocortisone in a dose of 0.1 mg 2 or 3 times a day to increase the blood pressure. Or sometimes they can be started on midodrine in a dose of 2.5 to 5 mg 3 times a day, which helps to increase the vascular tone and the blood pressure. If you find that the episode of fall is related to the long-term use of benzodiazepines or other sedative hypnotic drugs, what you get to do is educate about the appropriate use of sedative hypnotic drugs or non-pharmacological treatment of sleep problems such as sleep restriction, tapering and discontinuation of the medication. Many times the postural hypertension and other things could be because of multiple drugs. So in such a situation you need to review the medications which the patient is on. Sometimes the fall could be related to environmental hazards. Home safety assessment with the appropriate changes such as removal of hazards, selection of safer furnitures with correct height and more stability, and installation of structures such as grab bars in the bathrooms or handrails in the stairs. If it is because of some gait disturbance, we need to go for gait training. Use an appropriate assistant device, balance or strengthening exercises if it is needed. Any impairment in balance or transfer skills. Balance exercises and training in transfer skills have indicated. Environmental alterations such as installing of grab bars or raised toilet seats need to be done at home. If it is because of impairment in leg or arm muscle strength or range of motion, restriction of movements like hip, ankle, knee, shoulder, hand or elbow, you need to undertake physiotherapy. Exercise with resistive bands and putty resistance training 2 or 3 times a week. With resistance increase, the patient is able to complete 10 repetitions to the full range of motions. So we'll sum up by saying that the critical steps in reducing this risk of falls in the elderly includes elimination of environmental hazards, improving the home support system, providing opportunities for socialization and encouragement, modifying medications and restraints of using multiple medications, provide balance training, involve the family in the process of rehabilitation and provide follow-up. There are certain other general principles to be remembered while evaluating an elderly patient with trauma. That is, first of all, when you are dealing with an elderly patient who has a trauma, In the cardiovascular examination is important because sometimes you will find that vital signs may still be normal in the elderly in course despite the significant loss of blood. It is because the catecholamines which are less likely to, the elderly are less likely to produce an increase in the heart rate, and thus tachycardia may not be present. Blood pressure readings can be sometimes misleading. A blood pressure that would be considered normal in young should be looked at with suspicion in the elderly, which is much more likely to have baseline hypertension. The elderly patient is unable to maximize the cardiac output in presence of blood loss. He attempts to compensate this by increasing the systemic vascular resistance in the early post-injury period. The net result of this increase in resistance is to worsen the cardiac output despite maintaining a normal blood pressure. That is important to suspect an internal injury if the patient has a normal blood pressure. When treating elderly patients with intravenous fluids, we should see that there is no fluid overload by keeping and monitoring the internal jugular venous pressure and looking for any features of basal crepitations. Ringal lactate is considered better than normal saline, though it has the risk of inducing hyperchloremic acidosis. Osteoporosis is also a significant factor in the occurrence and severity of fractures secondary to trauma and contributes to the mobility and motility associated with the injuries. Further, you need to look into the pulmonary status of the individual, because sometimes following the trauma there could be disruption of the lower cerebral sphincter which may predispose them to aspiration. The most important point to emphasize is that the immune system in elderly people does not function as efficiently as that in young adults, and therefore they are prone to infection. Hence, the approach to the elderly patient with trauma would include primary survey including resuscitation, secondary survey, and then the definitive management. In the primary survey, it is important to keep the airway clear, free of blood, vomitus and secretions, remove any loose dentures. The airway can be achieved by jaw thrust, chin lift and finger sweep methods. We should always keep the possibility of an underlying cervical spine fracture in every patient, and therefore one should be very careful while moving the neck. Instead we should immobilize the neck using a soft collar or keeping sandbags on either side of the neck, avoiding use head tilt method to open the airway, as it may produce further injury to the cervical spine. Breathing. After obtaining an adequate airway, intubate either through endotracheal or nasotracheal route. The neck and chest should be looked for any deviated trachea, crepitations, absent breath sounds, flailed chest, and if you suspect there is a pneumothorax, a tube need to be inserted. In the circulation, you have to examine and see the pulse, auscultate the heart to rule out any cardiac arrest. If it is present, static cardiac compression. Collect the blood for the grouping and cross-matching. If the patient is hypotension, you administer crystalloids, preferring lactate. In presence of shock, you may have to administer as much as 1 to 1.5 liters of fluids over a period of 15 to 20 minutes. Carefully monitor the patient for any evidence of fluid overload. If the patient initially improves but then deteriorates or fails to respond, blood products should be administered, and imminent and emergent surgical intervention is many times needed. While assessing the disability following the trauma, we perform an abbreviated neurological evaluation by looking for the level of consciousness and the pupillary size and the reaction to light. This is important to rule out any imminent threat of cerebral herniation. It is important to emphasize that while evaluating an elderly patient with trauma, you remove all the clothing of the patient without any movement of the neck. And remember, there is no place of modesty in managing trauma patients. While doing the secondary survey in the physical examination, it is important to perform the examination from head to the chest and to look for any deformity, look for any site of blood loss, particularly the tympanic membranes, to determine if there is any hemotympanium or if there is a bleeding from the nose and ears. Look for any discharge of cerebrospinal fluid leakage. Re-examine the pupils, examine the chest, be sure the trachea is in midline, check the carotid pulsations, and look for jugular venous distensions. re-evaluate the chest for any evidence of subcutaneous emphysema, bony crepitus, deformities, or absence of breath sounds or muffling of the heart sounds. Abdominal inspection is important to look for any wounds, burns, or any tenderness, guarding, rigidity, organomegaly, and auscultation for the bowel sounds. Similarly, it is important to look for any evidence of scrotal hematoma or urethral rupture. Similarly, it is important to look for any pelvic fracture, and if you find that there is no evidence of any scrotal hematoma or blood at the urethral meatus, or then you can do the catheterization for measuring the urinary output. After secondary survey, we get a series of X-rays for the final diagnosis with respect to the site of the trauma. Apply a splint to the fractured extremity so as to reduce the movements of the fractured bone fragments. Further, after the evaluation of the patient, the final management will of course depend upon the nature of the injuries which have been detected by the primary and the secondary service. Therefore, the management of an elderly patient with trauma needs not only an integrated approach by a physician, but also you need the help of sometimes general surgeons, orthopedic surgeons, radiologists, and anesthetists. Therefore, it is an integrated approach which would help us to have a successful management of the trauma cases in the elderly. Thank you.
Yeah, but sir, can you just briefly tell our student that because most of them are working in a primary setup, so
yeah,
in a case of accident or like a kind of gait disorder, because many investigations are not available in the primary care, so what are the things they can perform at the primary care level, and what are the things they can, if somebody is posted in the secondary level hospital, so that they can further refer to the patient for the better care? If you can just describe.
See, in the primary healthcare center, it may not be possible for you to do the definitive treatment. It's not possible.
But what are the supportive things?
Supportive treatment basically is that you have to see that whether the patient has any obvious fracture anywhere in the body or any evidence of any tissue injury anywhere.
If fracture is there, that immobilization is the one of the
can be done. Yes.
Yeah.
And you will have to see whether the patient, is conscious or he is unconscious, whether he is in hypotension.
Yeah. Stabilization of
the circulation is important.
Yeah.
And then of course whether there is any blood loss, that has to be seen. That part can be taken care of. And even if you don't have any facilities of blood transfusion, at least the plasma expanders can be used to support the circulations. And then obviously at the earliest moment you need to transfer the patient to the nearest.
Side by side they can manage some kind of like airway cleaning and all these things also.
These basic things of maintaining the airway and other things can be done at the primary health center.
If some kind of just cardiac arrest occurs, they can just
resuscitate the
primary care.
Yes.
These are the things they can be done. So dear friends, as Dr. Kar already described very briefly regarding the poisoning as well as accident of the elderly, especially mentioned along with this balance disorder, because most of the accidents are related to the balance, movement of balance there. And side by side also it is need to be taken care that environmental hazards is also one of the issue regarding the accident of these, because it may be slippery tiles or the bathroom may not be properly cleaned and all these things. There are small issues which really it is an accident prone area, so for the elderly especially. In case of poisoning, the very first thing you have to remember is the detailed history as well as examination is very much important, and like common things, if you are not getting precise history, because most of the cases precise history is not available, the common things like gastric levers, activated charcoal, and like forced alkaline diuresis, and all the supportive treatment you can give at a time to support the patient for the further management, for the further reference of the patient. The same way in the accidents also, the definitive treatment you cannot perform at the site where you are working in the primary healthcare setup, but you can definitely support, and your good history as well as examination can definitely help to the patient for the better management. Here we would like to stop in these sessions, and I would like to thanks to all these students who are viewing our program. Unfortunately, we haven't received any call from any of the centers, and I also would like to thanks to our regional directors and their staff to make it available to our students. And definitely I would like to say thanks to Dr. Anuradha as well as Dr. Kar and the team of the MPC who are making possible this program available to you, and I would like to say thanks to you all. Thank you very much to all of you.